Hi, this is Larry Bauer. I'm Chief Executive Officer of the Family Medicine Education Consortium, and we're very excited to be partnering with the Sam Welly Foundation on launching an integrative health learning community. And I'm going to turn things over to Dr. Wayne Jonas, who is the Chief Architect for this activity, and he's going to share with you plans, what we have in mind.
Great. Thank you, Larry. And welcome everybody to this Q&A session around the Person-Centered Integrative Health Learning Collaborative that Sammy Welly Foundation is supporting and FMEC is being the host of in these areas. So what I'd like to do is I'd like to just give you a brief sort of overview of what it's about. And hopefully that will fill in the basic questions you have as to what the goals are, what the involvement is, what's provided, what you all need to provide to be part of it, and you know, the timelines and commitments and that type of thing. And then we'll just open it up for questions and answers to fill in any details or any specific items that you have. I'm gonna share my screen here and go through a couple slides that I think will probably answer, hopefully will answer a good chunk of questions here for most people. And let me, can everybody see that? Are you viewing basically a slide set here? It says FMEC Learning Collaborative for Integrative Health, Person-Centered Care. Great.
Yes.
Yes, yes.
Great. Okay. Well, let me go through these a few slides here, and that will, I think, clarify what we're talking about. Let me first of all a little background as to why we're doing this and why it needs to be done in healthcare in general. And I think this is probably well known to most people, but in case it's not, I'll try to quickly describe it. Medical treatment, that is what I learned in medical school, what goes on in most practices, is not getting at sort of the underlying determinants of health or the root causes of health, especially for chronic diseases. It's wonderful, obviously, for acute diseases or if there's a mechanical thing that needs to be done. But when it comes to underlying health, it actually isn't very effective in producing health. In fact, it's been estimated, it's been demonstrated that if everybody had platinum level health insurance, if suddenly we waved a magic wand and everybody got health insurance, it would only actually improve the health of our population by 15 to 20%. And that's been shown many, many times. And the reason for that is that the underlying determinants or root causes of health come from other areas besides medical treatment as it's currently provided. A big chunk of it from behavior and lifestyle components, and a growing chunk, unfortunately, of the social determinants, social needs, social and economic indices in those areas. And a lot of that has to do with the physical place that you live and where you come from. And so if health really wants to be part of the solution in terms of creating health for people, both on an individual and a population-based level, they need to go outside of this top little corner of the black area of this ring and begin to provide support and in the other areas, or at least ways in which those determinants can be addressed. And this is a challenge because most of the health dialogue that goes on within the clinical encounter focuses up in that top area and not in the others. So we define a new way of going about this that does this, that actually begins to produce health and is not simply providing more health care as we know it. We use the term integrative health for that. There's other terms that are used, whole person care, whole health, a person-centered approach. But fundamentally what it is that is the merger of conventional medicine. You know, we don't want to abandon good conventional care. It's important when you need it, but we want to include and incorporate good evidence-based, non-pharmacological approaches, sometimes called complementary and alternative medicine approaches, and most especially self-care approaches, behavior and lifestyle components shown in the green circle here. And that merger of those three is what we mean by integrative health. Now, all that has to be done within the context of the individual and their social environment. And so those factors also have to be considered in doing and successfully integrating and delivering integrative health. And so it's really the goal of this collaborative to take tools from a variety of places and begin to do this on a routine basis. So with that in mind, the goals of this collaborative are really that the participants who join, I'll talk about the limited spaces that we have for this, will come away both understanding the crucial role of self-care non-pharmacological approaches for reducing risk factors for chronic illness. And by the way, the pandemic has shown a spotlight on the need for this even greater than simply chronic disease management. Those who are at risk for COVID contraction and severity are the same ones that are at risk because of chronic disease determinants in those areas. And so the best way to build the population's resistance, in addition to preventing exposure, is to actually reduce chronic disease in the same way. The second goal is to learn to use a set of tools that have been developed and drawn from a variety of systems around the country that we put together in order to streamline the deliveries, to make it something that can be done routinely in clinics. It's then to do a test period of implementing those health visits within a subgroup of patients, and that subgroup is up to you and your clinic based on your populations and your needs, and then to collect some both process and outcomes data on that to learn from this and exchange information across the different clinics in these areas to help facilitate making this a standard routine part of what's done in your clinic and or in a new area in the hospital setting or in the clinical setting where you work. We want these evaluated because we want to see how well it works, and we want you to be able to use it for quality improvement in your own setting. We've got some experts available for that. I'll show you in a minute. And so at the end of this, we hope that you'll actually come out with the ability to evaluate, analyze, and report back on what happened in the clinic at a national meeting such as the annual meeting FMEC does, direct primary care, any of the family medicine or FQHC, HHS, really up to you where you want to present it. But we hope by the end of this, you'll actually have a scholarly activity in which you'll be able to report back on this process and what happened in the clinic. There are two major organizations that are sharing resources to make this available and work for you. FMEC, that Larry oversees. That's the Family Medicine Education Consortium. You do not have to be family medicine to do this. You don't necessarily have to be a member, but they have a wide network, mostly in the Northeast, but increasingly around the country, to do innovation programs like this. The Samueli Foundation that I work for is a grant-making foundation whose goal is to make integrative health and whole person care routine and regular. And so they are actually sponsoring this and providing the funding for the faculty, the staff, and the other resources that you'll see in just a minute, and making it available at no cost to those who are accepted. We've got a stellar faculty. I mean, these folks are really experienced both in practice and practice change, in delivery of high quality care and integrative care. Connie Earle is a family physician in California who has worked doing integrative health and FQHCs in underserved areas for many years and is available for those. Andrea Gordon, associate professor at Tufts University, who's recently come out with a 4-part CME series on integrative approaches to chronic pain and opioid use that'll be available to the participants. Elena Rosenbaum from the Albany Family Medicine Clinic. Both Andrea and Elena have taught this at I Am For Us, at FMEC and other sites. And then Alan Shaughnessy, who is the Director of Education and Quality Improvement at the Cambridge Health Alliance. And he will be our consultant and available to you to help develop the evaluation, the quality evaluation within your clinic, and the research components and evaluation components of this. So these faculty are going to be available throughout the time, and we're limiting the number of participants to this to between 12, at the most 15. I would prefer 12, and then each faculty will have a small number that are available and readily available for these clinics for assistance, in addition to the monthly meetings that we'll have. We're drawing a number of tools together, again, with the goal of streamlining and making this something that you can do within standard mainstream practice. So hopefully, if you do join, you will find a population or clinical site or providers that want to do this. And as you begin to do that, you'll begin to put in the infrastructure. It makes it easier. I hear over and over again from folks trying to do this as they feel like they're sort of the lone wolf. They're out there trying to do this, but it's not really embedded in the practice. And the goal of this collaborative is to make it so that it's easier to embed it in the practice and anybody can do it. To do this, we're drawing, as I said, from a variety of places. We've adapted something from the Veterans Administration Whole Health Program, the model of which I'm showing you here, called the Personal Health Inventory, and adapted it for non-VA populations that streamline the change in dialogue that needs to occur. That is then documented through a process called the Hope Note that I'll show you in just a minute. And the goal here is to empower and incorporate and equip patients and embed their behavior change and the non-pharmacological approaches as a treatment, a series of treatment modalities integrated into their standard care. And so this is a model I really like because the approaches really show exactly what needs to be done. Now, the process is actually very simple, and we'll be providing information to do this, bringing tools in for preparing the dialogue with patients, because many patients, they need to understand what the encounter is going to be like. They need to know what integrative health means, what it means for them in those areas. And I and a number of other clinics around the country have been doing this now for several years, and have developed processes that allow for that rapid dialogue shift that occurs during what we call the integrative health or the Hope visit, and then how to set up ongoing continuing support so that the behavior change and or other types of non-drug approaches can be easily and routinely delivered within your setting. And so hopefully at the end of this, you'll have actually a number of resources and a resource portfolio that you can draw on that you've customized to your practices. We'll provide some that are easy to deliver universally and that are free, but then you'll want to add and adapt those to your particular clinical setting. Here's sort of the sequence of processes that the clinics that we're working, the hospital systems we're working with now are using the personal health inventory and the Hope Note to engage and educate both the providers and the patients to address drugless approaches and complementary approaches, and address the social and readiness factors that are needed. Then equip and empower the patient in behavior change and access to some of those. That often requires some additional training, and we'll provide a lot of that access to that training for health navigation and health coaching. And then that ultimately allows you to provide ongoing support that then becomes a new way of engaging treatment for many chronic conditions in those areas. The resources available for this, and this is a partial list only of the resources that will be made available. These have all been developed in hospital and clinical network settings around the country that are already doing this. And that includes working agreement, overview, background materials, both for patients and providers about what this is. Some metrics, and you'll be developing your own metrics based on your clinic. How to finance this? That's always a big question. We have a coding and payment guide for this, and so practices will be looking at how to structure that within their business plan so that the bulk of this can be financed. Embedding it in the electronic health record is key. We have a template that is available to use that, and there are practices that have already done this within Epic, and we'll show you those. A number of patient educational tools, both PHI is already in English, Spanish, and Portuguese. We'll be translating other things to that. The Hope Visit itself, including the checklist, some example videos that you can watch in between meetings to see how it's being done in different places. A draft solutions guide that you can build on for your local community, and then ongoing support by the faculty, monthly learning sessions, etc. And then, of course, resources to make this easier to do through team care, the CME, chronic pain, group visits, and health coaching components that will be provided during the 9 months of the Learning Collaborative. Here's the general timeline. A more specific one will be laid out when we launch, but the first 3 months are really customizing and adapting the tools to your environment. Many of you already do integrative health, or at least you do aspects of what I just talked about. I hope you do. So really what we're looking at is taking some of the tools that are available for streamlining this process, combining them with what you already do to provide something that works in your clinic. Developing also the plans for the evaluation as part of that. We're putting together an evaluation component, and we're looking into getting an umbrella IRB approval, probably through exempt status of that you can utilize if you don't have an IRB. But most local clinics and hospital systems have their own IRB that also needs to look at it, but you'll have that available for you. Then there is 6 months of actually executing the plan that you developed and the tools, using that and with patients and gathering data from the providers and the patients. And again, this is where Alan and others will come in and assist in that. But that's really execution. The monthly meetings will allow you to learn, what challenges come up, because there will be and are challenges that come up trying to put even simple things into routine practice, and how that has been solved by others in the group or not solved, as the case may be, and you might collectively come up with that. Our faculty will be available. And then at the end, we'll have a 3-month period in which you can analyze, create your presentations, practice that with the other groups, if you're planning to do this to submit it to a national meeting during June to August. Many of you have residents, and this is sort of the ideal kind of scholarly activity that a resident can participate in. And if there's, last year their residency, they may want to finish this up by June, and so we'll try to time it that way. But we'll also have the ability to practice in July and August for those that don't need to finish up by June in those areas. All right, so what are the commitments for those that join? Well, you have to submit an application. We are trying to get a diversity of groups, and we've got a number that have already have applied. We're going to limit it, like I said, to 12 to 15 at the most. And so we want people who are willing to commit, and there's some basic questions on the application. You can get the application from Denise Steele. I think she's on this call. There's her email right there. And the deadline for the applications is towards the end of the month, September 25th, in which case then we'll be going through and selecting out who participates in this. If you do participate, you'll be asked to commit some time of either faculty, providers, residents if you have them. Here's what we recommend. there needs to be the commitment of enough support and behavioral health change staff that you can actually utilize these tools appropriately. We estimate it's about 10% of time during the 9 months of the collaborative. However, note that many of that time it can be spent doing these visits, which you should be able to bill at least partly for, as part of your routine practice. And so wouldn't cost 10%, but we'd like you to come to the table with a commitment of time of people that are actually going to do this and do this well. You need to agree to develop a plan. There's an agreement for those that accept it, say they will develop a plan. We recommend that a minimum of 25 to 50 patients be done during that period of time per provider. For those that have more providers will be more, but that's sort of a number that really allows you to trigger the learning challenges that are going to occur in your system and begin to solve those problems. Evaluate and collect data. Again, this can be part of a practice improvement component. And Alan Shaughnessy is looking into, for those of you who want to use it as a practice improvement and get credit for that, you can do that. If it is strictly practice improvement, usually that doesn't require RB approval, but if you collect patient outcomes, which we recommend you do in terms of the impact on health and wellness of your patients, that does require it. And as I said, we'll be putting together a umbrella IRB, probably through Tufts or some other national qualified IRB. But during the first 3 months, you'll be developing your own plans to put into your local IRB if you need that in those areas. Everybody needs to agree, obviously, to attend each monthly meeting. Most of the learning materials will be offline, and we'll ask you to view those so that we can spend maximum amount of time at each monthly meeting, really exchanging information, talking about what happened in the PDSA cycles or the improvement cycles, and problem solving to move forward. And then agree to present the results at least within the group by the end of the year. And hopefully you'll have something that your participants can present at a national meeting. Here's some of the data collection that we recommend. These are all made available to you. The personal health inventory. We're looking at, counting the number that's done per provider. This has been adapted from the VA. The Hope Note itself, again, this is internal and will be provided to you. We strongly recommend, we understand that everybody may not be able to do this, but we'll provide support for this, that a standardized metric for documenting improved wellness, which we often see in patients who engage in this, occurs. Promise 10 is the simplest NIH validated tool. And we're looking for change scores over the period of the delivery. And then there is a healthy days metric embedded in the personal health inventory in those areas. So there's a number of other data sets that are data points and metrics that can be done. We've got a whole list of those that you can select from, drawn up based on the quadruple aim. In terms of patient experience, in terms of costs, et cetera. And if your clinic wants to collect that data, we encourage that and we'll assist you in putting a plan together that allows you to do that. Here's some key dates for this. The deadline for applications is September 25th. Again, if you're interested, please get those applications. You can get them from the FMEC website or email Denise Steele directly. Her email's there and she'll send you the application. The FMEC has a pre-conference workshop for an hour in which all accepted participants will come together, introduce themselves, meet the faculty, get a basic orientation. The official launch is October 13th, in which all materials then will be available and a portal accessible, and you can begin the planning process. We'll go through the process that I outlined before. Denise is there. I saw she turned on her video. Hi, Denise. Say hi to everybody. She'll be helping to manage this this collaborative. And
hey, everyone.
Great, thank you. So there she is, and again, email her if you'd like an application. And the application. And then but June 8th is when we're looking to begin the presentations on what we found. During the monthly meetings, we hope all groups will be actually testing things out in small groups of patients and exchanging information on how what challenges come up during that time and how those things will be solved. We've got several applicants already who have done this and started this last year. And we have a number of applicants that do integrative health already. But again, remember, this is about learning how to make this a standard part so it's easier for anybody within your system, network, or practice to be able to begin to do this. And it makes it easier, hopefully, for you to be able to do it in patients in those areas. So anyway, that's the end of the overview. I hope that provided you with sufficient details to understand what this is about, and excited you about being able to participate. Looking forward to having a number of people who are on this call hopefully apply. And there's some basic contact information for folks on my side, over on FME's side, and Denise's email there. So I will stop at that point, and we're open for any kinds of questions that people might have. And make sure you unmute yourself here.
One question I had, right now at CFL, we have only one afternoon a week of a provider actually at CFL in the physical building. So if we applied and were selected, would the thought be to then take this model into the regular family medicine outpatient clinic setting? Would that be the ideal of what you'd like to see happen?
You know, this has been designed and is intended mostly to have the breadth of flexibility for primary care, okay? And although we have folks that are not family medicine who have applied, we've got some pain clinics that want to do this. There's some pediatric groups. I mean, that's primary care, but it's not family medicine in those areas. And so taking the first part of this, it would be good for you to think about where you'd want to do it. Okay, first of all, coming in, but during the first development phase, the first 3 months, you'll be solidifying exactly where that's going to happen, who's going to do it, and that type of thing. And so that will allow it to be adapted to where you want to do it. A family medicine clinic is a great place to do it, because the family, I do it within 2 clinics myself. I do it within a family medicine residency program, very busy, and I do it within an internal medicine clinic. Okay, I do it within a pain clinic and a general medicine clinic also in those areas. And so yes, that would be ideal, what you just described. Now, you brought up the point that you only have one afternoon a week where people are face-to-face, and COVID has changed the nature of the whole visit process, right, in general. And so many of these tools actually are readily adapted to virtual delivery. I do almost all of this, not all of it, because sometimes you can't do that, but if I know the patients, if they're part of the standard panel that I'm part of, then I can easily do this virtually, and I do most of it virtually. And a lot of this is education, it's self-care, it involves getting some assist. Many of the integrative approaches can be actually delivered virtually, not all of them, obviously. Acupuncture is a bit of a challenge, and that type of thing. And so, but a lot of it can. And so part of what we're going to be learning together is how to do this virtually, as we all learn how to do virtual care in general. Part of what we'll be providing as we go into the main part of the year is how to do group visits. And so we have one of the top folks. He's not on the faculty, but he'll be a special guest that'll come in. Jeff Geller, who has done group visits for years and has a system down that has been shown to be very effective. And he's now, and we have done virtual group visits with him. I've done virtual group visits in this area. So if a good bulk of those folks are going to be done through virtual group visits, that may be an approach that you'll also want to take for some of the patients to support some of the patients.
So in the actual application, we do not have to, at this point in time, have identified we're going to incorporate this in Dr. Smith and Dr. Medina's clinic on Tuesday afternoons, every Tuesday.
If you
the
can,
work in process.
yeah, if you can get to that level of specificity, you will be ahead of the game. And so it'd be great to have those conversations and think about, all right, where would we do this? And we ask that in the application process because we're looking for readiness, and we're going to be picking practices that are ready, right? We don't want practices that aren't ready and don't really want to commit to the time. But during the first 3 months, a lot of the detail will be worked out. You can say, our plan is to do it here and here, and these are the interested parties. They will be participating in some way. But if it doesn't end up in that particular clinic, and as you begin to develop this and spend some time on it, it shifts somewhere else. That's good. We don't want you to get to January and still not know where you're going to do it. But you don't have to necessarily have it up front. The more the more specificity you have based on the application questions we have, the greater readiness you'll have when you launch.
I have a
You're muted.
Oh, Christine, you're muted.
I must have hit it twice.
Yeah.
So you mentioned about having support staff available, like a nurse or a social worker, and I'm a health coach. I'm just wondering, are you providing any training for those people if we identify, they have the mindset, but they just don't have the degree of integrated medicine training or health coaching training? Is that part of it as well, to train people besides the direct physician or their medical provider?
Yes, absolutely. Great question. And yes, this is delivered best by team care. Okay, it doesn't have to be. There are physicians that are in direct primary care and other places that they just do the whole thing, right, themselves. But in most practices and the future of healthcare, this is delivered through team care. And so this is why we ask, who else is going to be part of your team, behavioral health, health coach, et cetera. We will be providing training on some of those skills. We're not here to provide certification to become a health coach. Okay, so if you want to do that, we'll certainly put you in touch with how to do that. We'll bring some of those elements into it in those areas. We have, again, a special guest that'll come in a couple times this is her area, and she'll provide that kind of baseline and be available for that. And we'll also then look at adapting the health coach, health navigation process, because it's often a hybrid of these skills. If you go and do your wellness coaching certification, they don't tell you how to apply it in clinic, right? You got to figure out how to do that. We're going to be providing that kind of a discussion and support for that process. So the answer is yes. And we would want the entire team to participate in the learning, doing the the offline stuff that's available for you, as well as participate in the meetings. And so we'll break up the groups so that that can be done more effectively in small groups as we do that virtually. And it's best to have the whole team there.
Including if we got residents involved, they would be able to attend those meetings and everything. That's great.
Absolutely, yes. There's a number of residencies. FMEC, has a huge group of residencies. A number of them have indicated they will have applied in this area. And this then is the scholarly activities for the residents, right? So, yeah.
I have another question. Assuming successful completion and meeting the objectives and the presentation at the national meeting, going forward, what is the thought is the plan to make the clinics that participate in this, to have it be a self-sustaining program, or are there thoughts of this is part one and then there'll be part two, 2021, 2022, with an ultimate goal of X or Y or Z? What are the thoughts going forward?
Yeah. So, I mean, we're getting a lot of interest, so there'll be continued clinics that probably want to continue this process that are not going to be able to participate. So we haven't decided exactly what to do with that. Our hope is, and some of the tools that I indicated on the list there are things that ought to help you become as self-sustaining as possible. Now, even primary care is hard to self-sustain, right? And especially if you're in a fee-for-service environment. I mean, COVID has blown that completely apart. And so there has to be creative ways in figuring out how to sustain these processes. But many of the clinics we work with within a population health framework have shown that they can sustain this, that they can actually get it paid for. If they're in a hybrid system, some of the coding tools are very helpful in terms of that area. And so the hope is you will have moved a good way towards sustaining what you've developed in those areas. At this point, we haven't decided, okay, well, what do the graduates do after that? And is there a way to support that? But I think it'll emerge during that time. During this coming year, when this is going on, there are huge discussions, as you know, going on within healthcare in general about shifting the payment model for primary care, because it does not work, okay, and to have a fee-for-service component. And so we're going to bring some of that into that discussion. Our foundation works with many of those groups. We're looking at possibly funding a National Academy study on global financing for primary care. And that includes integrative health and that type of thing. We'll see how that emerges, but we'll bring that information to the collaborative as it emerges, and hopefully that will help with the sustainability question in that area.
Other questions?
Mm-hmm.
I just had a technical one with Denise. One of the emails I received from you had the, click here to download the application, and it wouldn't open. It was asking for some kind of a username or.
Guys, sorry. Can you repeat your question?
Oh, just that one of the emails that were part of this invitation and conversation had the application linked to it that I just couldn't open because I was just wanting to oversee the application. And it was asking for some kind of, I can't remember if it was a username or a password or something to get into it. And I didn't know if you could resend that or what the options were, because I couldn't actually see the application.
Okay, yeah, I can resend it to you. I know with the system that we use a membership database, and it also is kind of the source. That's what our website is built off of, and all of our forms. So it'll collect the email address because that's kind of what it's doing. It's doing its job, basically collecting that email address when you log in. So by logging in and entering your email address, you're in no way like becoming an FMEC member or any sort. You're pretty much just in our database as a prospect at that point. So it should ask you for your email address. So, but other than that, and I will definitely resend it to you. So, and if you want to have a short phone call, even offline, I can help walk you through it.
Uzama sent in a question on the chat box asking about the participation of residents. And I don't know, Uzama, if you can get off mute, you could clarify that. If not, I can address what I think you're asking. How does it work for residents in general? And we've got a number of clinics that have residencies. And actually, Larry, maybe you can even address this, but this is, the residency needs to have a faculty, obviously sponsor, especially if they want to make this a scholarly project, if they would like to sort of be a lead in that. They need to have faculty sponsor to participate, and that we ask for that on the application process. But very often, one or two residents are participating in this, and they're actually leading the development of the evaluation component. They may be doing some of the visits, et cetera, under the supervision of the faculty. They come out with the skills at the end of this to be able to do it and to teach other residents. They can present within the residency itself, but they're often the ones doing some of the evaluation and delivery work in that. So I don't know if that answered your question or not.
Yeah, I think so, because I was thinking as a resident, if I'm interested, I have to get a faculty who is also interested on board, since the patient care has to like be something he agrees with. So do I have like resources where I can like show the faculty of what this whole thing is all about, so they can have like an overview of what I'm talking about?
Right. There is an overview, and Larry and Denise, maybe you want to address that. Maybe you could send us the description of the project itself. There is I think a 2-page description. It's on the website, the FMEC website already, so you can link there, but perhaps you could go ahead and send that to them with the application process, and hopefully that would give you the information that you need to approach a faculty and say, hey, can we do this?
Okay.
Yep.
I did update the website probably within the last week and a half, and it has all the resource links, has the application, and I can share that in the chat box too, the website for the page. I'll do that here.
Okay.
The other
Thank
thing
you.
is this session is being recorded, and probably by the end of the day today, it will be available. We can send it out to everybody who's been on the call, and if you want to then use that to inform your faculty person, I would encourage you to, as a resident, to find at least one faculty member who appreciates what you're doing. I mean, you're
Okay.
going to have a faculty supervisor signing off on the care that you deliver. So this should not be a surprise to them. So I think it would be important to find somebody ahead of time. And the other thought that I would have for that faculty member is getting a copy of Wayne's book, How Healing Works, will give an in-depth understanding for them about this whole approach to care.
Okay. Thank you very much.
Okay.
Other questions?
Somebody did ask in the chat box about getting the recording. So Denise, if you could just send the recording out when it's available to everybody on this, then they can use it as they need to. Great.
We will do that. There is a recording out there already too from the July session. That's on that same website page that I sent out to everyone.
So I think we are all finished. Wayne, thank you very much for leading the session today. And thank you to everyone who joined with us.
Yeah, thank you, everybody.